and we will I think we'll have a discussion after it, because we need to listen. But you're just very correct that the most important thing in the treatment of OPLL is choosing of the approach to avoid the complications. And so I think we go to the next speaker. The next speaker will be Dr. Zan Chen from China. Hello.
Hi.
Yes, you can continue, and then I think we'll try to we'll make the discussion at the end, because I think we need to listen to all the data, and then we'll just see the most important, discuss most important topics. Thank you.
Okay, I have shown. I share my screen. Is it
Yes.
okay? Okay.
Yes, for sure.
Good evening, everyone. Because it's midnight in Beijing, and my topic is about ACAF for cervical OPLL. I'm Dr. Chen from.
Sorry, we don't see your slides.
Really?
There's a black screen.
Have the slide?
No, we cannot see your slides.
We cannot see your slides.
Sorry. I share it again.
We have black screen.
Zan, it says you have started screen sharing, but it doesn't start. Please unshare and then share again. Dear Zan, can you please share the screen now?
Yeah, I'm trying.
First you can stop your sharing, and then you can start again.
Yes,
okay.
we already just stop sharing. Now you can activate your screen. By the way, we have now more than 110 participants who join us.
Hi, is that okay?
Okay, we're all right. Yeah.
Oh, great. Thank you.
Yeah.
Sorry about that. My topic is ACF for cervical OPLL. OPLL is very high intensity in East Asia area. So in our center, we have many kind of these cases, like this kind of cervical OPLL. And a new technique has reported in 2018. It's called ACAF. It's a kind of idea, a kind of technique that we enlarge the cervical spinal canal in the anterior approach, and does not need to remove the OPL lesion. So with this technique, we can reduce the incidence of CSF leak. And in China, we have performed a lot of studies on this technique, and we can see that if we perform a laminoplasty, the spinal cord have to shift backward to away from the anterior compression. So the spinal cord will change its normal shape. But when we perform ACAF, we enlarge the cervical spinal canal with anterior approach. The spinal cord can be decompressed just in situ, and the spinal cord does not need to move away. And so this will reduce the incidence of C5 palsy. And also, we know that if the K line is negative, when we perform post-approach laminoplasty, sometimes the result does not so good. But in the study, we found that if we perform ACAF, no matter the K line is positive or negative, we can get a good result for the patient. And also, they have compared ACF and ACCF, and they found that the enlarge of cervical spinal canal is much better, much effective with ACAF, and better than ACCF. And also, the doctors have compared ACF and laminoplasty, and they found that C5 palsy and axial pain is much more decreased significantly. But the some the dysphagia and hoarseness is increased because this is related with anterior fold approach. And so also the curve of the cervical spine is much better. Use anterior approach ACAF, and SVA is much is better with an anterior approach. And if the K-line is negative ACF, we will get a better result. And from 2019 to 2023, we have performed 55 cases this technique for OPLL patient, and we have some very satisfied result. And but this technique is not difficult. So there in the beginning there did some have complications, and we have one case vertebral artery injury, and there is a CS leak in 3 cases, and there is 6 cases. So vertebral body does not left enough, and in one case we performed posterior decompression in addition. The most difficult part of this technique is how to cut open the vertebral body on bilateral side, because the OPL lesion is sometimes irregular, and sometimes the lesion is laterally. So sometimes when in the beginning, if we cut the vertebral body not so properly, and will cut open the OPL lesion, and it's very easy to lead to a CS leak. And also we should pay attention to vertebral artery, because a lot of this kind of patient, the vertebral artery have some abnormal running. So before operation, we have to check CT angiography to evaluate the vertebral artery. And I have shown some cases. My first case is a male, 58 years old. He has performed laminoplasty 8 years ago, but he still have a lot of symptoms. And on X-ray, we can show that he has performed laminoplasty, and but CT scan showed the OPL lesion is very huge, and the spinal cord is still be compressed in the anterior side. So I do the operation, and I published my first case of video. And this is how we do the operation. First, we do ACDF for every level, from C3 to C7. But in the levels that there's a OPL, we do not need to remove the ligaments totally. We just remove the disc. And then we cut open the vertebral body on bilateral side with a bone with a burr. You can see the vertebral body are cut totally open. And then we plant a plate, and with the and then cut the vertebral body on right side. And then we can use the screw to pull the vertebral body upward and decompress the spinal cord. And this is on the journal we published this video to explain how to do the operation. And before operation, we can see the spinal canal is stenosis, but after operation, the spinal cord is the cervical spinal canal is enlarged, and the spinal cord is decompressed much better. And the second case is also male suffered a very huge OPL lesion. MRI showed the spinal cord is compressed. He has performed post decompression and fusion technique. And after decompression, we can see though the spinal canal is enlarged, but the spinal cord is still compressed on the anterior side, so the patient still have symptoms. And we performed the ACCF for this patient for revision. And after surgery, we can see we can totally enlarge the cervical spinal canal. And after operation, we can see the spinal cord is totally decompressed. And the patient symptoms can get much better. And this is before operation, after the first post-decompression operation, and this is second anterior decompression operation. And this is how the spinal cord decompression is changed. We can see after the first operation, the spinal cord, the anterior side is still have some compression, but after ACF, the compression is totally relieved. And the third case is a 37 years old male. He suffered weakness in 4 extremities for 6 months, and MRI showed very severe decompression of the spinal cord, and CT scan showed the OPL lesion. And we performed the 3-level ACF for this patient. The spinal cord is decompressed. And this first case is the most severe case in my case series. It's a female, 49 years old. And before operation, 1 day before operation, he suffered suddenly paralyzed in 4 extremities, and his lower extremities muscle strength is 1 grade. And the CT scan showed a very large OPL lesion from C3 to C7. And this is X view showed the OPL lesion. And the MRI showed the spinal cord are decompressed severely. And this is X view of the cervical spinal canal. And I performed ACF emergently for this patient. And the operation lasted for 10 hours, and but it successfully decompressed the cervical spinal canal, the spinal cord. and MRI showed the spinal cord is decompressed. And 3 months later, the female patient have no neurological symptoms left. And this is another patient, 52 years old. He suffered lower weakness of lower extremities for 5 months, and on admission, his left muscle strength is decreased, especially the lower extremities is decreased to 1 grade. And MRI showed a very severe compression of the spinal cord. CT scan showed a very large OPLL lesion. And we do operation emergently for this patient, and 2-level three-level ACAF. And after operation, the spinal cord is decompressed, and the patient symptoms relieved at the 2nd day after operation. And another very special case is a male, 79 years old. He has performed ACDF 25 years ago and laminectomy 10 years ago, but his symptoms is severe, still very severe. And this is X-ray showed he has performed ACDF 25 years ago. He used a special cage, and so he has also performed laminar posterior decompression, but the spinal cord is still compressed. X-view showed the how severe of the spinal cord is compressed, and CT angiography showed the anterior body was totally fusioned together of the 3 level, and the CT scan showed on the posterior border is OPLL lesion. And we found the cage is too laterally to very close to vertebral artery on one side, very close, only 3 millimeter near to the vertebral artery. So we performed the ACCF for the patient. We pull up the 3 vertebral bodies to save the time we escape the video. And after operation, we successfully pull up the 3 vertebral body anteriorly. And you can see after operation, the spinal canal is enlarged. We compare anterior and posterior operation. And the spinal cord is totally decompressed. And also, we progressed this technique to Kolosky technique. That means we can more carefully design how we perform this technique, and then use the more carefully planned technique. We can reduce the fusion levels, and that means for this patient, if we perform ordinary ACF, we have to pull up C3, C4, C5, and also C6, 4 level. But with more better planned of the technique, we only pull up 2 level, and the fusion the 4 level, we can totally decompress the spinal cord. And this is a very special case, 66 male patient. on MRI showed a very severe compression of the cervical on the cervical spine, and X-view showed the spinal cord is compressed. And this C7, and the CT scan showed a very multi-level of OPL lesion. And on the CT angiography showed a lot of bone hydrate on the anterior border of the cervical spine, and it's very dangerous to perform ACF at C4 level because the vertebrate running is very it's running irregularly. It's very easy to hurt the vertebrate at here. So we do a very carefully planned technique. We just pull up C3 and decompress the cervical spinal cord. And this is the video of our patient. And to save time, I'll skip it. And this is after operation. You can see we just pull C3 upward and to decompress the spinal cord. And this is how we perform the operation. We just pull up C3. And the spinal cord is decompressed successfully. And because with the anterior procedure, the patient recovered very quick. On the third day, he can be discharged. And we write a chapter on this book of ACF to describe this technique. And now we're running a randomized study to compare ACF and laminoplasty for some cases, which especially with the cases the K-line is negative. And to finish my lecture, I would like to say that ACF is a very powerful technique for cervical OPL, and microsurgery is very helpful for the technique. Thank you.
Thank you very much for a very interesting presentation and a really excellent technique. Very modern. Thank you very much. I think we have